Hello, everyone. This is Jeanette Gass from IASP, and I would like to welcome you to today's webinar. Today's webinar is one in a series related to the 2020 Global Year for the Prevention of Pain. There are several ways to participate in the webinar today. After the talks, we will have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be recording this webinar, and it will be available on the IASP website after the live broadcast. You can also tweet using hashtag Global Year 2020 and follow at IASP Pain on Twitter. Now I have the pleasure of introducing our first speaker, Dr. Rianne Van Boekel. Dr. Van Boekel. Dr. Van Boekel is a trained nurse, teacher, epidemiologist, and researcher who acquired her PhD in medical science at the Department of Anesthesiology, Pain, and Palliative Medicine. She is currently assistant professor at the Department of Anesthesiology, Pain, and Palliative Medicine of the Radboud University Medical Center in the Netherlands. Her research is focused on acute postoperative pain management, prediction, and assessment of pain. She is an active member of the Research Department of Anesthesiology, Pain, and Palliative Medicine at the Radboud University Medical Center and participated in various research projects aiming toward bringing research closer to the public society. Rianne, welcome to our presentation.
Thank you very much, Jeanette. Dear participants, welcome to our presentation focusing on acute to chronic pain after surgery, prevention, assessment, and management from a nursing perspective. Next, please. These are my disclosures, as you can see. I have no paid relationships with the industry. I think that's most important. Next, please, Janet. Well, this is what we are going to talk about in our session. As you noticed, I will start with a short introduction about different topics of acute and chronic pain after surgery and ideas about prevention and management. After that, my colleagues will continue focusing more deeply on some nursing interventions, such as adequate pain assessment and promoting health literacy. Next, please. To start with the epidemiology of acute postoperative pain, as you can see in this slide, the prevalence of moderate to severe pain did not change very much over the last decades. So it's still necessary to talk about prevention of pain, how to identify patients that are at risk for pain and provide them with adequate treatment. Next, please. For the identification of patients at risk for acute postoperative pain, several studies identified risk factors to build a nice prediction model. However, the ultimate prediction nowadays does not exceed 70%. Despite the fact that we do not have the perfect prediction model, we can still use these factors, such as a younger age, female sex, psychological items, to become aware of potential patients at risk and take precautions. Next, please. Because we know that the consequences of inadequately controlled postoperative pain may be very severe. It decreases functional recovery, quality of life, having a major impact on the psychosocial situation of patients, as summed up at the right side of this slide, such as increasing anxiety, inability to sleep, loss of control, etc. Also, the risk of post-surgical complications, more physically, is increased. Next, please. Me and my team have done some research on that topic to prospectively investigate the association of acute postoperative pain and the development of complications after surgery. In this slide, you can see a figure from our paper showing that there was a linear relationship between the level of movement-evoked pain, measured by numerical rating scale, as you can see on the x-axis on the figure, and the incidence of complications on the y-axis. The incidence of complications increased when the NRS, the numerical rating scale, became higher. Next, please. The complications that were documented in the medical file of the patients in this study are shown in this table, showing the category and the exact complication. You can see mostly gastrointestinal complications, such as nausea and constipation, but also infectional, of course, and pulmonary. It is a wide variety of all kinds of complications, resulting mostly in extra treatment and an extended length of hospital stay. For now, I will focus on one complication that was documented, persistent pain. Next, please. And then I mean persistent pain in terms of chronic post-surgical pain, which is a phenomenon that's nowadays highly recognized. And it's recently received an updated definition. You can see it on this slide, and it's included in the International Classification of Diseases, the ICD-11. Next, please. Oh, no, not yet, sorry. It is defined as pain after surgery that has at least 3 months of duration, localized to the surgical field, and is not better explained by another cause. Now you can do the next one. Thanks. Although only 3% of chronic pain finds its cause in surgery, it occurs in 1 or 2 of 10 surgical patients, and then becoming an intolerable condition in 1 of every 100 surgeries, leading to severe consequences and a decreased surgical outcome, rehabilitation and quality of life, increasing functional limitation, psychological trauma, and of course, the healthcare costs. Next, please. The incidences are procedure specific, as you can see in this table, and they vary between the procedures. In this table, you can see the incidence of all chronic post-surgical pain, but also the incidence of the severe chronic post-surgical pain, which is a little bit lower in most cases. And you can also see the proportion of neuropathic pain, which is not always reported, but there are a lot of differences in incidences. For example, look at the incidence of the cesarean delivery and the sternotomy, which differ a lot. Next, please. Also, for the development of chronic post-surgical pain, several risk factors are described in international literature. In this table, you can see them divided into the pre, intra, and post-operative period, on the top of this table. The identification of preoperative and intraoperative risk factors is most desirable, of course. To identify those at greatest risk to preventive measures can be taken optimally, but risk factors captured in the acute postoperative period, so just after surgery, may still offer a chance for mitigation. For example, those identified as being at greater risk in the hours or days after surgery could be referred for early involvement of an acute pain service, or early management and follow-up by a transitional pain service, or APS outpatient clinic, which I will address later on. So also in the postoperative period, it's possible to identify patients as risk and think of prevention strategies. These risk factors can also be divided into different domains. You can see them on the left column of this table. Some may not be amenable to interventions, but others are. However, all factors should be taken into account when treatment plans are made for individual patients. The multidimensional nature of these risk factors plea for a personalized treatment plan rather than a standard ward protocol, as is most used. Because of the nature of the risk factors, such as psychological issues, pharmacological as well as non-pharmacological interventions may be necessary. One key risk factor you can see in this table is the type of surgery, which means that we have to look procedure specific. Next, please. Well, this brings us to the key messages of this first part of my lecture about the high prevalence of acute and chronic post-surgical pain having adverse effects on outcome, physiologically as well as psychologically. That several multidimensional risk factors are known and can be used for personalized multidimensional prevention and treatment consisting of pharmacological and non-pharmacological interventions. Next, please. Well, let's continue then with the second part of my lecture. It's about pain services. It's recommended that facility in which surgery is performed have an organizational structure to oversee the development, implementation and evaluation of policies and practices to assure safe, evidence-based and effective postoperative pain management. Many hospitals installed an acute pain service for that service, which is a dedicated and specialized team, preferably multidisciplinary. Well, there's a very wide diversity of APS structures because there's no consensus up till now, which is the best model. There's no agreed definition of what might constitute such a services. Two main types have been recognized, one with the physician more present than any other way, but there are several varieties. Some may be low-cost nurse-based, others are led by anesthesiologists, but rely primarily on APS nurses without daily clinical participation by an anesthesiologist. And some are comprehensive and multidisciplinary services with APS nursing staff, sometimes pharmacists, physiotherapists, and daily clinical input. from anesthesiologists. Well, the first one, which was described in literature by Reddy in 1988, was a service mostly covered by physicians, residents, but his team also included a clinical nurse specialist. Well, in 1994, a low-cost model was described by Professor Rawal, focusing on specialist nurses in his team, but also empowering nurses on the ward, supervised all by anesthesiologists. Since then, nurses had a more prominent role in these services, as we can see and also in other studies. Next, please. For example, in training and education of nursing colleagues, the implementation of standard orders to simplify pain management, the implementation of regular assessment of pain, and the improvement of interprofessional cooperation and communication, which may be very important in handling patients traveling through a hospital, on the OR, the recovery, the ward, etc. Next, please. Well, individual publications assessing the benefits of an acute pain service have reported that the presence of an acute pain service reduced pain scores, led to a lower incidence of adverse effects and postoperative morbidity, such as chronic post-surgical pain. But it's very difficult to meaningfully analyze the benefits or otherwise of an acute pain service because there is no definition, no central definition. It's possible that acute pain services may benefit patients in other ways, for example, in early recognition of neuropathic pain and institute appropriate treatment or something like that. Next, please. Well, that brings us to a rather new development, a kind of extension of acute pain services following patients after discharge to monitor and prevent problems such as chronic post-surgical pain or potential opioid addiction. In this slide, you can see two papers describing such services. It's a transitional pain service described in Toronto, Canada, and the APS outpatient clinic in Finland. Because nowadays, the length of postoperative hospital stay has been significantly shortened. Some patients still experience severe pain after surgery as discharge, for example, or postoperative pain may persist longer than expected. And we think that the subacute phase after surgery, so when people are already at home, may have opportunities for continuing treatment in order to prevent extra problems, such as chronic post-surgical pain or opioid addiction. It may be possible to prevent or mitigate the development of persistent postoperative pain by early recognition and multidisciplinary treatment of persisting subacute pain before plastic changes in the central nervous system lead to a more persistent or even permanent condition. Therefore, the follow-up service for patients at risk, called a transitional pain service described in Toronto, Canada, or APS outpatient clinic in Finland, have been developed. So what they do actually is a preoperative identification of patients at risk of severe acute pain and or persisting postoperative pain, and take care of effective and safe pain management in the subacute phase, also preoperative, intraoperative, postoperative, but also when people are at home. This includes appropriate and controlled use of strong opioids and anti-hyperalgesic drugs, also at home. It provides a way to monitor the link between preoperative risk factors, perioperative analgesia, and persistent postoperative pain. Next, please. Let's take a look more deeply into the methods of the transitional pain services in Toronto. This transitional pain service comprehensively addresses prevention of problems like chronic post-surgical pain or potential or actual opioid addiction at 3 stages. The first one is preoperatively, the preoperative assessment before surgery. Second one is postoperatively when patients are in the hospital. And the third one is postoperatively in an outpatient setting for up to 6 months after surgery. Patients at high risk are identified early. This can be preoperative or postoperative, and offered a coordinated and comprehensive care by a multidisciplinary team, which consists of pain physicians, advanced practice nurses, psychologists, and physiotherapists. They also use pharmacological as well as non-pharmacological interventions, such as a brief psychological intervention. This is a perfect example for the future, where we can see the continuation of quality of care and pain management into primary care. Next, please. In summary, The key messages contain the importance of acute pain service and transitional pain service, or outpatient clinic, of course, and the need for personalized multidimensional prevention and treatment, consisting of pharmacological as well as non-pharmacological interventions. There are some nice examples of nursing interventions also about prevention, and my colleagues will continue addressing some examples into more detail. Thank you.
Thank you for that excellent presentation. I would now like to introduce our second presenter, Dr. Petra Mandysova. Dr. Mandysova was formally trained in nursing and became an associate professor in 2018. Her current nursing practice and research efforts focus mainly on evidence-based patient assessment and nurse and patient education, mainly in relation to pain management and neuroscience care. She has translated the Iowa Pain Thermometer Revised into Czech and promotes its use in the Czech Republic. She has contributed to the development of the European Pain Federation core curriculum for the European Diploma in Pain Nursing as one of the members of its development team. She has also studied pain-related health literacy and pain assessment in various patient groups. Let's welcome Petra Mandysova to our presentation today.
Thank you, Janet, for your introduction. And I'd like to say hello to everyone. It's wonderful to see participants from all over the world. Janet, could you please advance the slides for me? Okay. So let me start by saying a few words about comprehensive pain assessment. As you already heard, and as you probably know, the pain assessment needs to be comprehensive. It needs to include basic domains, 3 basic domains that we frequently come across in the scientific literature, and I believe in the clinical practice, we know that there are these 3 domains, the biopsychosocial domain. They are quite interrelated. So there should be initial determination and also ongoing assessment of pain and all the relevant factors in these domains. I provided sources at the bottom of some of my slides, including this one. So you're very encouraged to read the articles from which some of the information on the slides was taken. Okay, so although the pain assessment is comprehensive, should be comprehensive, in clinical practice, what very often happens, the assessment is done in a simplified way, and very often it focuses on only selected aspects, especially pain intensity. And pain intensity is actually a key factor that guides treatment decisions. Which is not ideal. This is not really sufficient. Janet, could you advance the slide for me, please? Okay, very good. So perhaps nurses sometimes are confused or don't think of all the important factors they need to consider. And to help them with this, some experts in the field have devised various mnemonic tools that can be used quite efficiently. So let me just mention some of these mnemonic tools. For example, the WILDA approach, which includes 5 basic components of pain assessment. Words used by the patient to describe pain. It means that the nurse needs to ask, tell me about your pain, and the nurse listens to the patient. Then pain intensity, location, and duration. Does the pain come and go or not? Is it always present? What makes the pain better and what makes it worse? Also, it's important to assess other relevant factors, such as sleep. Does pain affect sleep? Does it affect appetite? Does it affect energy levels, activity, recovery from surgery and illness, relationships, or mood? Next slide, please. We should also check vital signs. We should inquire about past medication history. We should know about health literacy and knowledge of pain, about the patient's beliefs and misconceptions. And my colleague Nadja will talk about health literacy in more detail later on. We should know about use of non-pharmacological measures. We should also know, or we should inquire whether the patient is experiencing any other symptoms such as nausea, vomiting, constipation, and so on. Next, please. Another mnemonic tool available in the literature is called KISS-taped. It again contains the 5 components that I have just talked about, but it also contains other components such as the past response, preferences, expectations, goals, and meaning, which, as you can see, focuses not only on the bio dimension, but also on the psychosocial dimension of the pain experience. Next, please. So we have talked about what nurses need to assess. Now let's talk about how we can assess the patient. So normally self-report is considered the gold standard of pain assessment, and we use a variety of instruments such as scales, pain thermometers, and so on. And even patients who are not able to talk for various reasons can still use self-report quite efficiently if, let's say, they are given a piece of paper and a pen, so maybe they can write. If they cannot talk, maybe they can use gestures and so on. Next, please. Also, we need to search for potential causes of pain. For example, are there any pathological conditions present, such as surgery or history of persistent pain? What about common procedures? Is the patient undergoing rehabilitation activities, or are we planning any wound care? Are there any other problems that may be causing discomfort, such as constipation, infection, and so on? And if pain is expected or suspected, then we should provide, or we could provide, an analgesic trial and observe results. So for example, if the patient is supposed to have a physiotherapy session, then we would give the patient pain medication just prior to his physio to make it more manageable. Next, please. If we continue in the hierarchy, so if the patient is not able to self-report pain for a certain reason, we can still observe patient behavior, and we can use various behavioral instruments. And there is a lot of behavioral instruments available. Some instruments even use combinations of assessment techniques, such as the Rotterdam Elderly Pain Observation Scale, which is actually a behavioral instrument supplemented by proxy assessment. And this particular instrument is actually part of the Dutch palliative care guidelines. So this one is used in clinical practice, and also the authors have developed a very nice educational website that is available. Proxy reporting is used quite a lot. So it's reporting by family, reporting by caregivers. However, we need to know that this kind of reporting may be inaccurate. Sometimes these caregivers or family, they overestimate pain or underestimate pain. Next, please. Of course, there are challenges associated with the use of instruments, and we should be aware of these challenges. For example, many versions and modifications of a given instrument exist, which makes comparison difficult. If you think of the FACES pain scale, you may have come across various modifications of the FACES pain scale. Sometimes instruments are not used properly. Sometimes the instruments don't even contain instructions. So nurses don't know how to use these instruments properly and how to record pain using these instruments. Are they valid? Are they reliable in which populations? So there should be evaluation of psychometric properties should be done, but this is not always the case, and it's not always done. Translation of instruments from one language to another is a very lengthy and costly process. And sometimes the translation is not transculturally equivalent. Sometimes only the instrument is translated and the instructions or the interpretation is not translated. So it's a complicated issue. Instrument usability. There is not much research done on instrument usability. Research focuses mainly on user friendliness, but also there are questions concerning such questions such as, are they easy to learn? Are they error tolerant? Are they efficient? And so on. Next, please. Just to give you some food of thought, I really like this picture. It was taken from the Wong-Baker Faces website. How did the Wong-Baker Faces pain scale, how was it developed? Well, it's actually based on children's sketches. So they took a group of children, and the children were given a sheet of paper with 6 empty circles and were asked to draw faces representing different pain intensities. And we know that typically in Faces pain scale, pain intensity increases from left to right, but in this girl's sketch, pain increases from right to left. So this leads to a question whether the left to right direction is actually correct. How about cultures and languages in which people read and write from right to left rather than from left to right? So I don't have the answer for you, but it's something to think about. Next, please. Okay, if we think of some of the populations that require a special consideration when we assess pain, of course, cognitively impaired patients is one group of patients where we need to assess patients carefully. Some may still be able to use simple self-report instruments if they're able to cooperate, but we have to be aware of other potential problems. I have worked quite extensively with patients with stroke, and stroke is one of the leading causes of morbidity and mortality worldwide. And what happens in these patients, sometimes they are unable to interpret facial expressions due to right hemisphere stroke. So they would not really be able to use Faces pain scales properly. Some have visual field defects or neglect syndrome. So horizontal pain scales may not be suitable for them, and instead they may have to use vertical scales. And this is what we also observed when we translated the Iowa pain thermometer into Czech. So the patients actually preferred to use the vertical pain thermometer rather than horizontal instruments. The elderly is another group of patients. They have multiple comorbidities, and so we have to assess these patients very carefully. Next slide, please. Children is another group of patients. Age and cognitive development, of course, influence their pain assessment. Self-report, including simplified self-report using simplified Faces pain scale, could be possible. There is some interesting research emerging in 3-year-olds, 4-year-old children. I could mention recently not yet published a paper by Tina Janist from Sydney, Australia. So she has worked with very small children and with these simplified pain scales. Women is another group of patients, minorities, people from other cultures, and so on. Next slide, please. Okay, if we think of assessment of risk factors and associated factors, so it has already been mentioned that we use a biopsychosocial approach. You have already heard about risk factors for pain. it's important to identify modifiable risk factors and to work with patients so that these modifiable risk factors could be prevented. For example, let me mention interesting research done in the United States concerning low back pain. They actually, in this study that's mentioned on this slide, they did a review of medical records of 26 million Americans, and they found that patients with a history of nicotine dependence, obesity, depressive disorders, and alcohol abuse were at a higher risk of developing low back pain. And in Finland, another fairly large study of over 3,000 participants showed that low back pain was more prevalent in those who had a history of obesity, smoking, and strenuous physical work and using vibrating tools. So if we work with our patients and if we educate them about the importance of smoking cessation and reducing obesity, then we also contribute to the prevention of pain. And then there are psychological factors and also low health literacy that could be a factor, although the cause and effect relationship is not always clear. Next slide, please. I mentioned health literacy. So what is health literacy? It's the overall ability of patients to seek, understand, appraise, and act on health information for optimal health, which plays an important role in the management and prevention of chronic pain conditions. So it's not only the knowledge that they get, but they also, ideally, they need to take this knowledge and act on that knowledge for optimal health, for doing specific things, such as what I just mentioned, let's say reducing body weight if they're obese and so on. Unfortunately, there are significant gaps in research, which was described, for example, in a systematic review on health literacy and its impact on low back pain management, and in a scoping review of chronic pain health literacy instruments that our team has done. We have come to the same conclusions that, in fact, there are gaps in research, and most research is done only in some countries, such as the United States and Germany, and research in non-Western countries is urgently needed. Next, please. So what is the key message and clinical implications of my presentation? So a comprehensive pain assessment includes 3 basic domains: the biopsychosocial domain. A hierarchy of techniques can be used as a framework to guide assessment, and we should always do our best to try to use self-report. Self-report is the gold standard. We should avoid the potential pitfalls associated with particular assessment techniques and instruments. And we should know that there are special populations that require special consideration. This is, of course, based on your clinical practice area. So if you work with children, you focus on children. If you work with seniors, you focus on seniors. And finally, when assessing risk factors and associated factors, nurses should help prevent modifiable factors and minimize the impact of non-modifiable factors. So this is the end of my presentation. Thank you. And now will be the last part, and Janet, you will take over now. Thank you.
Great, thank you for that presentation. Next, we have our last speaker is Dr. Nadja Nestler. Nadja works at the Institute for Nursing Science and Practice at the Paracelsus Medical Private University in Salzburg, Austria. Her research is focused on the care of people with chronic diseases. She is currently a member of the expert working group for the actualization of the German expert standard for pain management in nursing for acute and chronic pain, and was previously a member of the working group on the development of the European curriculum for nursing pain management. She is also involved with the German Pain Society. Please welcome Nadja Nestler to our presentation today.
Thank you. Thank you, Janet, for your introduction. And dear colleagues, it's nice that we have so many attendees today. On this slide, you see my disclosures, and as Janet says, I'm an assistant professor at the Paracelsus Medical University in Austria, but on the slide I marked Germany because I live there and I'm a member of the German Pain Association as a chapter of the IASP. So I want to talk about health literacy and the reasoning for pain management, especially nursing pain management. So Janet, please, the next slide. In the last talk, Petra spoke about some necessities and possibilities related to pain assessment, and she ended with the role of health literacy. And here I will continue. For a good and effective pain management, the patients need a good health literacy, in my opinion. They must be able to find, to read, to understand information, and they have to decide which information is necessary for them. This is important because they must handle competent, in particular, if they have chronic pain. And for this handling, they have to got sufficient information which they understand and which they could find. So we know that in many times people with chronic pain or with pain are not able to find information, and when they find information, they are not able to decide whether this information is a good information or not, and they also don't know whether they can speak about this with their nurses or their physicians. But we also know that especially when people have chronic pain, they have to get the role of an active partner, and we have to make them to an active partner and an expert of themselves to maintain the quality of life. So we have to change the patient's role. Next slide, please. When we look for the European, for Europe, what is the situation here in Europe, then we can see that in most of the countries we have no good situation, because most of the people have a poor or fair health literacy, but most of them are far away, especially the younger adults, from having a good health literacy, and we have to change this situation. Next slide, please. When we look at this slide, you can see that the health literacy status is varying in different European countries, while in the Netherlands, where Rianne van Boekel come from, more than 70% have a sufficient health literacy. In Spain, more than 50% have a problematic or inadequate health literacy. And we also see this in other countries like Austria or Bulgaria. So several studies about health literacy shows that the status of different groups show that especially most of the persons with a chronic condition and also with chronic pain have a problematic or inadequate health literacy. Next slide, please. And we know also that low literacy skills predict a negative health outcome. The health information is often not accessible for those who are affected, and chronic conditions will arise because of insufficient health literacy, and also chronic pain as one chronic disease arises because of not handling acute pain in an adequate way. This problem has different aspects, and at first health information is often not accessible for them who need more information, and the information itself is frequently not understood, as well as the ability to select the right information is limited by the patients. The next slide, please. Due to these aspects, there is a need for a health literacy interface between the health settings, the professionals, and the affected persons. We should describe the necessity of a good health literacy so that all people have a self-interest to be informed. But for this, we must give information which can be understood and is relevant for each person. That means we should give the relevant information and must bring the information to the persons in a way they could understand and could recognize them as relevant for themselves. So we have to change our perspective to the patients in pain, and we have to look what is relevant for them in their individual situation. Even we must consider the different areas of life and the necessity of health status. Next slide, please. These aspects have implications for the nursing process. So at first, we need knowledge about all phases of care and the different phases of having pain, from acute to chronic pain. And we as nurses must be informed about the different phases so that we can plan which information is necessary for the patients. Nurses can promote the independence of their patients while they assess the knowledge of the patient about his or her individual pain situation, as well as the competences and activities of daily life. And this is our special interest, to look at the activities of daily life and to support the patients to have a good outcome and to have a good quality of life. With the knowledge about the knowledge of the patient and his or her competences, an education for a rapid and trouble-free recovery is possible, and the patient will be enabled to actively support the process. It also means that the individual needs for a sufficient pain management has to be surveyed and evaluated in the process, and we should be a mediator between patient and also other professional groups for planning the treatment process. Next slide, please. This leads to various nursing tasks. Nurses communicate with the patient about his or her pain and pain situation. So Petra talked about the pain assessment and the necessities to talk in various ways. And we provide information as well as psychological support to enable the implementation of pain management in everyday life. Nurses plan the discharge of their patients, including the integration of skills in the activities of daily life to ensure rapid discharge. And this is an important aspect, as we all know. This means especially the implementation of the pain therapy in everyday life. And for this, we need an education of patients in preparation of the discharge. So they need to know something about technical tasks. They have to learn as well as the aspect of self-monitoring and so on. And when we have patients with a complex pain situation, we have the need to involve nursing pain experts in order to be able to process the patient's specific needs. So in my opinion, it's you need a specific knowledge and specific competences to support these patients. Next slide, please. This brings me to an aspect. So we know that patients have specific experiences because in the effect of postoperative pain, and several studies show the impact of postoperative pain on patients. We know that preoperative anxiety has a relationship to the severity of pain, and negative effects could be drawn of preoperative pain, catastrophes, psychological stress, symptoms of anxiety and or depression, and somatoform disorders to pain and function after maybe total knee arthroplasty. Postoperative pain also has an impact of satisfaction after joint surgery, and this shows the studies. And postoperative pain depends on the fulfillment of the preoperative expectations on the surgery, in particular of the achievement of satisfactory pain relief after the surgery and the total hospital experience. So we see that the patients have specific experiences when they have surgeries and what will happen with their pain. Next slide, please. But patients are highly motivated to be an active participant in their own recovery process, but their possibilities are influenced by the information behavior of the health professionals, so by the physicians as well as by the nurses. And they are also influenced by the occurrence of postoperative complications, especially the pain, and also due to insufficient pain management. On the other hand, patients experience the need to adapt to the standard therapy, so that there is nobody who looks on their specific or individual situation, and this does not correspond to the expectations for an individual treatment. For that, they think that the behavior of the health professionals hinders their individual recovery, and also patients experience a rapid discharge from hospital as problematic because they frequently feel insufficient prepared in the hospital for their discharge. Next slide, please. So for that, nursing education is necessary, and for a better pain management, we must empower patients to handle their pain and their pain management in a better and sufficient way. One example can be an empowerment training program for people with total hip endoprosthesis, as we will present you here. This program consists of a baseline assessment and an assessment as well as education in the process. At baseline, the individual situation will be assessed, as well as the demographic data and history, the family and support system, and the arthritis symptoms and functional status in this specific training program. And in the process, the actual care situation will be assessed, the wound status and the pain situation, and belonging to all this information, nurses give instructions on behavior with the operative hip and the advice on realistic objectives, and make a further review of possible changes and, if necessary, of an adjustment of objectives. So you see that an empowerment training program is not one situation, it's a process, and we need to support the patient about some days or weeks. So next slide, please. This study of Huang showed that this training program with an empowerment education is suitable for patients with chronic pain, and showed significant differences between the intervention group and the control group of the study. But they also show that it is necessary to focus on personal situation through the assessment, and an alignment with the individual goal are seen as crucial. So we have to look at the individual goals and to handle out what are the goals of the patient, what is possible, and what are the goals for handling the pain management at home. Next slide, please. Another example I will show you is a new app, the app Recovery. We produced and established this at our institute here in Austria. And we conducted this to empower patients with a hip or knee replacement. And this app is developed to giving the patients specific information to develop their health literacy by a structured educational process. So the patient receives specific information in several phases, from the preoperative phase, the phase around the surgery in the hospital, the rehabilitation phase, as well as the time after discharge at home. And next slide, please. The app integrated several concepts, and you see here these several concepts. So we have reflection and the motivation, a gamification concept, as also the education. And one important concept is structured self-monitoring during the hospitalization, the rehabilitation, as well as at home. And here the patient is invited to monitor his or her pain, the activities and the wound status, to recognize changes and to talk these changes to nurses and physicians, and to have a feeling for him or herself. Next slide, please. We also integrated short animated videos for explanations. So these movies show what is pain assessment, why you have to assess pain, how you can mobilize yourself, and how will function the rehabilitation, and why we have to get some assistance from our relatives. Another aspect, next slide please, education movies, and here we make these movies with some patients, and they show how we can leave the bed in the right position, how we can get out of the bed, how we can put on our shoes, and so on. And so I'm able to look at these videos as a patient and to remember how I have to make this, and because the app belongs to me from my preoperative situation to the time 3 or 5 months after surgery in the situation at home. This app can support the patient in several situations and how he or she has a necessity. So in my next and last slide, I also want to give some key messages and clinical implications. So we know that many people have a problematic health literacy, also the people in pain, and we have a great need for the optimization and support. And the educational support has to be oriented at the resources of the individual person and the life situation, and we have to set individual goals. And new media can us support, and can the people support. It's possible, and also it's useful, but I think we don't want to forget the nursing task. So it's only can support, but it can't leave our talk to and with the patient. So thank you very much.
Great, thank you all for those great presentations. We have several questions in the Q&A. I see some of them are being answered as we were having the other presentations, so that's great. The first question in the Q&A I think is for anyone really, but one of our attendees asks if any of you have any thoughts about why epidemiology hasn't changed so much since 1995.
Rianne, do you want to give an answer?
Can I answer that question? Yes, I answered some quick answers live, but because we have such a small time left, maybe it's good to know that all questions will be answered and will be later on. But for this question, yes, I do. Well, of course, nobody knows exactly, but I do have an idea by myself, because I think that the last decades we have invested in research on pharmacological interventions for the prevention of pain. But as you can see in all these risk factors, only the physical risk factors will be dealt with pharmacology of course, and having epidurals and having regional anesthesia and all these kind of sorts, which I think these are very good, but it's not only those things that will prevent pain to develop. So I think that there should be far more research on non-pharmacological interventions. Yes, that's what I think, but maybe some other people have some other thoughts about that.
I can answer this question from a German perspective. I know that pain and pain management was no theme for a long time in the nursing as well as in the physician's education. And so you learn something in the practice or you didn't. And so also nurses did not saw pain and pain management as a theme in their practice. And now we have the situation for 20 years, I think, that we accept that pain and pain management is also a theme for nurses and for their practice. And I know that the situation for many patients will be better now than 20 years ago. But I think there are also many nurses who don't know so many aspects of pain and pain management, and we have to do more and more education.
Great. So one of the other questions, and I think this is, I'm not sure quite who this is for, but one of the attendees asks if how can we assess health literacy? Are there specific questionnaires, or is there another way to do that?
Yeah, so there are questionnaires you can use, but the studies show that these questionnaires are important for studies, but not for practice. And there are some key elements for assessing the health literacy. So you have to look whether the patient is able to read. So sometimes you see that someone who has to read something, who give it a relative or someone else, or who forget something you talked about. And so you have to think about specific questions, how you can look for the health literacy. And maybe we also can answer this in a written way, because then I can write down some questions which may help you to find out how is the health literacy.
Could I just add also to this question, because I find it very relevant. As for simple assessment tools, one instrument that was developed in the US, I guess more than 15 years ago, is the newest vital sign, and it was translated to many European languages, to Japanese, perhaps to some other languages as well. It's based on a nutritional label, on a hypothetical nutritional label on a container, on an ice cream container. And there are some questions. It's a total of 6 questions that is given to people, and they need to, for example, based on the nutritional label, they need to say how many calories are contained in one serving, and is it safe for you to eat this ice cream if you are allergic to peanuts, and so on. So this is one instrument that could be considered. However, I recognize that maybe in some countries it's not common to go to the supermarket and buy food and look at nutritional labels. So again, here the aspect of transcultural equivalency, I think, plays a role. So I would say overall we don't have enough instruments to measure health literacy, yet it's extremely important to consider this aspect as well.
Great. We had a question through email that came before our presentation, so I want to make sure we get to that one. That will probably be our last question based on the time. So the question is, to what extent do nursing interventions that promote resiliency, such as teaching, relaxation, meditation, coping skills, and enhance self-efficacy help in the perioperative period and beyond?
Nadja, could you answer that question, please? I think it's based on your.
But maybe you can repeat it. It was a little bit
Yeah,
fast for me.
I'll repeat it. No, it's no problem. So to what extent do nursing interventions that promote resiliency and enhance self-efficacy help in the perioperative period and beyond?
Yeah, I hope I've understand it now in the right way. So the nursing interventions in the preoperative phase, yes?
Yeah, the perioperative, yeah.
Yeah. So we know that education in the preoperative phase is very, very important, because then the patients know what they have to expect after the surgery. And also when we assess the preoperative situation, we can look for the risk factors, and we can set individual goals, and also we can intervene when we know about the preoperative situation.
Okay, great. So unfortunately, we're running out of time here, but I will say that I will email the unanswered questions and we can get some answers and post those on our website along with the recording. I'd like to thank the speakers for the presentations and thank everyone for attending and for all of your interesting questions. Our website has information about the 2020 Global Year for the Prevention of Pain, and we will be posting this recording shortly. You will also receive an email follow-up with a link to the recording and other information about the Global Year and upcoming webinars. Thank you all very much for joining us today, and we look forward to seeing you on our next webinar.
Thank you, Jeanette, for your moderation and your wonderful support. Thank you.
Yes, thank you, Jeanette.
Thank you. Thank you, everyone.
And thank everybody for being here with us today. That's very, very nice.